This is kind of my first time with you guys here. Our residents actually have pioneered this for out here out east, and I've got like 4 or 5 family docs doing this. So for me, this is my first time here. But so I've got a 33-year-old gentleman who I've been taking care of for 5 years or so in our Suboxone program. And he's white, on Medicaid. He's got a history of opiate use disorder. Recently got out of jail. Previously had been on fentanyl, heroin, butylene, ethylene, amphetamine, cocaine, but mostly fentanyl and heroin. He does have a history of IV use with difficulty with actually vein access. Currently, interestingly, it's just he didn't used to smoke marijuana and somebody recommended a marijuana card. And now he's heavily smoking marijuana. So not sure that was a positive. He was diagnosed with Hep C in 2018 and was interested in getting treated now because he's got his life back together. He's got a good job as a foreman and, is at risk because of a better job of losing his Medicaid. So the reason I'm presenting him is he's got newly diagnosed hereditary hemochromatosis and he's homozygous. And he's currently on buprenorphine for his opiate use disorder. He has never been treated. His only generalized symptom is fatigue. And you can scroll up. He is immune to Hep A and Hep B based on antigens and antibodies. He's 6'3", 161 pounds. His white count and his CBC are all normal. Of note, his ALT and AST are in the 161 range and 94. Alk Phos is normal. Bilirubin was normal. His Child-Turk-Pugh score was 5. His MELD score was 8. And additional lab tests. His total iron was 280 with a ferritin of over 2,000. And so that's what led to getting the hereditary hemochromatosis gene testing. HIV's been negative. He's a little bit vitamin D deficient. Other sexually transmitted infections were negative. Ultrasound was negative. Because of his iron overload, we did get a liver MRI, and it showed some fatty liver and iron overload. I didn't have a chance to go to the radiologist, so I didn't bring those images because I wouldn't be sure what I was showing you. So my questions with him, in starting his Hep C treatment, are there any other considerations with his hereditary hemochromatosis? I would think he's probably at higher risk of liver failure down the road, but treatments, I'm assuming, urgent, indicated at this point. Any reason for not treating him concurrently with hematology, with phlebotomy, although we're facing a problem that he has difficult venous access, so that may be a limitation. And then are there any other testing that I should be performing? I'm looking for, alpha fetoprotein and alpha-1 antitrypsin, other tests. And then in talking with him, is his prognosis necessarily worse or any other special follow-up? And where we are, we have some GI docs, but none of them do liver disease at all. So, getting them either to Morgantown or somewhere else, what benefits would there be of that given the kind of constraints of travel and such? So that's the case.
Thank you so much for the case, Dr. Baltera. You did a great job as always, and I'm happy you're able to present a Hep C one for us today. But before we get into the feedback recommendations, anyone with clarifying questions for Dr. Baltera? Everyone's welcome to chime in and unmute.
I have a question. This is John here. Does he drink alcohol?
Fortunately, no.
So his vices are limited to other
Yeah, and
signs of abuse.
yeah, it's interesting. We have some people, but there aren't, you'd think there'd be a lot more people that are drinking and using heroin. It tends to be a separate population.
But maybe he has terrific insight into the natural history of liver disease, because it's a multi-hit hypothesis. Not even hypothesis, just like cancers and everything else. The more insults you give to a particular organ,
Right.
less likely it is to compensate. I wanted to commend you for thinking of hemochromatosis. Number one. Number two, I want to apologize because you're dealing with a infectious disease people here, so we're not hepatologists either. Now, Kaylee's probably the most educated on hemochromatosis of all of us, by far, but it's certainly a risk factor for progression of liver disease as well as the genotype 3. So I was really happy that you were aggressive with HCC screening, number one, and trying to establish whether or not the patient had advanced fibrosis. And apparently he does not, by liver morphology or F score. Ideally elastography could even be done if you have that, but you're out east, like Eastern Campus, you said?
Yeah, and actually it's funny because I picked up the phone and called Jessica Rude, who's now in her second year of practice, but was one of the residents who trained, and said, "What labs should I order for this guy?" And she said, "Oh, get an iron." And otherwise, I'm not sure. So I'm kind of we're rethinking that because, West Virginia is a small state. I don't know how many other people potentially, and I take care of his father. I delivered his son, and that's the beauty of family medicine. So we're going through all the genetics and, kind of figuring that out. He's got a brother who's probably most at risk for this, he's got a 25% risk. But we just don't, even out east, I think we're fairly lucky. We don't have any hepatologists or anybody. So I'm kind of figuring this out.
Well, I guess the good news is you can eliminate one of these hits from his liver. So
Okay.
you'll be able to cure him. You're catching him at the right time. He's got youth on his side, and you've got him before he has advanced fibrosis. Good time to treat him. And genotype 3, your options are twofold. You can treat him with Mavorite or Epclusa. He's not cirrhotic, so you don't have to do that special polymorphism testing ahead of time if you wanted to use Epclusa. I don't see any medications that limit usage of either one. So really your choices are either Mavorite for 8 or Epclusa for 12, whichever his insurance prefers or whatever the patient prefers. He likes 3 pills once a day or 1 pill once a day for a longer amount of time. You can sort of fine tune it. But again, I commend you for diagnosing him, and he'll then be left with only one risk factor for cirrhosis, after you eliminate that other one. A little historic perspective on ferritin. It's a confusing lab from all of us in the hepatology field. It can be elevated for a bunch of things, including drinking. I think Kaylee and I see it elevated with alcohol usage on occasion. And, obviously iron overload syndromes can run along with hepatitis. And then it can be, like in this patient's situation, a hereditary predisposition to it. So it's a tad confusing. It used to play a major, major role in predicting who would respond to therapy in the past. So this is back to prior to 2014, when we used interferon. We really wouldn't treat people with elevated ferritins because the response rates, instead of being 50%, were like 10. We used to bleed people ahead of time. So even if it was a reactive ferritin elevation, not even from hemochromatosis, we'd send them for phlebotomies before putting them on PEG interferon, for better or for worse. And then they'd be lost to follow-up, and Lord knows what happened. But nowadays, we don't have to worry about that as much. We just sort of a true unrelated, remove one hit from the liver, and certainly advise them to continue avoiding alcohol and stuff like that. That's about all I have on him. He's somebody who, I have a bias towards elastography for additional information that it can provide. MRI doesn't obviously show the morphologic evidence of cirrhosis, but what it doesn't necessarily show you is pre-cirrhotic fibrosis. So remember, cirrhosis morphology is that tiny lobular scarred down liver, but you can't see F1, F2, F3 necessarily on an MRI. And so if you have access to elastography, it would be a great.
Well, that's one of the things I've been talking to some of our docs that do the Hep C treatment, our family docs. And obviously the company has come out to talk to us about it.
Yeah.
And it wouldn't be feasible in like our offices, like my office or Dr. Rude's office, but as a central place, it may be, now that we're starting to see. And so it would be helpful to know, on you guys' opinion, how much that would add to our treatment. Because like I said, I think probably a lot of these are being done by family medicine right now, some by ID, but I've got 4 or 5 docs, and all the residents are comfortable doing it.
Awesome.
They've kind of led ahead of us, and kind of dragged us along, and it's true, Don, with the change of technology, this has been so much easier. Diagnosing one with hereditary hemochromatosis was ordering the test, and 10 days later I had the result. Um, Showing my age, but that I couldn't have imagined that. It's just a whole molecular chemistry thing going on now. So anyway,
Well
so
said.
yeah, so if you could give us some information, if you think that would be helpful,
My
I
personal
could try
bias,
to get the hospital to get it.
or send them here. If the patient would ever
Okay.
travel over, it's if they're a Mountaineer fan, coordinate with a football game or so. The Lord knows.
Got it.
Try
So you
to.
guys do have it and use it there then?
We have it here. I don't know where all has it. I think Garrett County has it, and where else, Kaylee?
Garrett County here, Fairmont, their Fairmont Gateway Clinic. Those are, Reynolds Memorial
Okay.
out in the,
Grant in Petersburg.
where is it?
Grant
Grant?
Memorial in Petersburg.
They have it too?
Yeah, I've been getting reports.
Oh, that's awesome.
That's awesome. Well, that's good because that motivates us. And is it housed like in radiology, or is it kind of in?
It's honestly variable. It's
Okay.
something that it doesn't technically, to do just an elastography score doesn't require all the detailed knowledge of how to perform an ultrasound.
Right.
I know that's probably pretty wild. It's actually easier. You just have to aim at the liver with 10 spots and push the trigger, and it gives you so some people do them in their office as like a billable procedure. Our GI nurses are possibly being trained in that one, our APRNs, and I think Dr. Tierney used to do it, if I'm not mistaken. But a lot of times it is housed in radiology. It's wherever the machine is. It's really
Right.
a different wand and a different software.
Okay. Well, we'll look into that for sure.
But if not, you might want to just, this guy's got so many reasons to have, not so many, but 2 reasons to have advanced fibrosis. And it matters from cancer standpoint. He's 33, if he's got scar tissue, you can cure his hep C, but if that scar tissue is there, it could still be oncogenic going forward. And you'd want to keep an eye on things because you'll likely cure his hep C. But
Okay.
yeah, but great job.
That was helpful. Very helpful.
How soon will he be losing his insurance about? Will it be in the next couple
It's,
months? What?
as everybody around here, it's kind of one of these. I lost a bunch of people because of the last year got dropped and they've gotten it back. But he's getting a foreman's job. So my guess is probably 2 months. So I already ordered his Maverick just because I'm like, let me get that in, just in case. So he's got it at least through the end of this month, hopefully next month, and hopefully he can get the 2 months of that. Now he may get, and this is the trade-off. He's got a better job. He has access to other insurance. I'm not going to say it's better than Medicaid. I get everything I need from my patients, but he may have to pay for it and it may be more expensive. So probably, I'm guessing 2 months. We may have, but hopefully it'll slip under the radar and he'll keep it longer. But
Rachel our pharmacist might be able to speak on this a bit better, but I know in the past when we've kind of been on the cusp of insurance potentially being dropped, then we've worked with the pharmacy to just try to get the, second fill dispensed as early as possible.
okay.
They're not almost done with their first fill, just to have, so that they have the treatment. Because if he does happen to lose access to his second month because of insurance lapse, you could also I guess have him do the patient assistance paperwork through the manufacturer, but that's just going to be more paperwork for you to do, where hopefully you can just bypass that.
All right, I'll call Allied because it's going through the WV
Allied is
pharmacy.
wonderful. Yeah, so I would say Rachel will they stay on top of it and they'll definitely work with you for that.
Okay, that's what I figured because
I was just going to add in, as so long as the pharmacy knows. So if we know about that, we do try to push the limit there. Medicaid does have some sort of rules they put in place on how soon people can, how early a fill can be. So we'll try to push that so that we can make sure, like, I'm going to go ahead and fill it this day, whether I talk to the patient or not, so that I know ahead of time, like, I'm going to need to fill this early before it ends on, March like the end of March or something to that effect. So if we know about it, we can try to push that to make sure they get it all. Because if you do go the patient assistance route, sometimes that drags on, and we've had some patients have some gap in therapy trying to bridge that. So
Okay, I will call you, Rachel.
Did you have any other questions? Did we answer everything pretty much?
No, I think part of it was he's also a good learning case for people in terms of multiple hits. That was kind of part of the reason I wanted to present him. And and do you guys get ferritin and irons on people routinely on everybody? Because
Yeah, we typically do, an iron study panel. And then kind of go from there. One thing, I guess, another point I would make, because I know you'd mentioned, could you treat them concurrently, or how would that affect things? And especially because he's a hard stick, so may have trouble getting phlebotomized, like you said. If you do treat the Hep C first, you might bring that ferritin level down enough that he may not need phlebotomized. So that would just be something to consider too. I'd still, you've already done all the right steps. He's already going to see hematology, but just something to consider from that standpoint too.
So it may not be as urgent, right? Get the Hep C treated, see where we are. Because I was even thinking, do we put a line in this guy? How much blood does he need taken out? All those things, because it is very difficult.
Yeah. So, I would just get his Hep C treated and then, try to go from there, because maybe he won't need phlebotomy.
Okay, great.
Yeah, John said he bets it'll drop 1,000.
Okay, well, that's again also really helpful, because that's kind of the first thing he asked me is, this is going to be a problem. And so he says, I can't, if it's donating blood, they can't get my blood very easily. And so,
Sure.
yeah, well, that's helpful.
Great case. Really, really great case. Thank you so much for sharing him.
Yeah, thank you all so much. I know Kaylee already asked you, any other questions about the case, Dr. Baltiera?
I got more than I wanted, so
Awesome.
that's great.
That's so great to
That's
hear.
helpful.
Awesome. Thank you so much for bringing the case today. It was really a great one and great learning one as well. And thank you, John and Kaylee and Rachel, for the feedback and recommendations to the case. If there are no further questions or comments about the case portion, Kaylee, I'll give you the ability to screen share if you prefer. I also have your PowerPoint on my end. So if there's any tech issues, I'm here as backup. Just let me know.
Sure. Let me try to do it from mine first.
Right?
If not, I'll let you know. Oh.
That looks perfect on our end.
I think though, is it now kind of wonky?
Yeah, it's a little zoomed in.
Let me try this again.
It was good for a second, and then the next slide was like zoomed in again.
How about now?
That's perfect. Thank you, Kaylee.
Okay, gotcha. So, for anyone who was either on last time or maybe not on last time, I had been talking about doxycycline as post-exposure STI prophylaxis. We had kind of already gone through most of the data. I'm not going to go through all of those studies again. I believe, let me skip through to where I left off. I believe we might have left off at the DPEP study. So just kind of to summarize, doxycycline as prophylaxis, post-exposure prophylaxis against bacterial STIs, so syphilis, chlamydia, to an extent gonorrhea, has been described in several studies, and CDC will likely be putting guidance out shortly for this usage. Just a summary of the studies so far. So mainly has been studied in men who have sex with men, either on PrEP or those that have HIV infection. So men who have sex with men and transgender women. There is one study that's been done, the DPEP study. This was enrolling 449 cis women ages 18 to 30 on HIV PrEP. This was a study based out of Kenya. 18% had already had an STI at enrollment. The intervention was a 1-to-1 ratio, so half of them got DoxyPEP, half of them didn't, but they were all on HIV PrEP, and the primary endpoint was time to first STI. So where we saw with the other studies that were looking at men having sex with men, and there was a significant reduction in mainly syphilis and chlamydia, about 50% reduction in gonorrhea. With this study, unfortunately, there was no significant change for the women taking DoxyPEP, which is really disheartening. You know, this was not something that was shown with our cis women. So why was this? Why did this happen? Why was it not effective? So a couple things that have been thought about initially was, you know, anatomy. So is there different tissue penetration for doxycycline in women, so in vaginal tissue than in rectal tissue, or even like esophageal tissue? And really, you know, what they found is that there were still, you know, effective levels of doxy in all of these tissues, and there really wasn't any difference in the levels. So that can kind of be ruled out. Were exposures any different? So were they seeing like different types of these or different exposure risks in these this population? It was in Kenya, you know, not in the US, so maybe there was some difference in that regard. Resistance, so were they already resistant to these medications to start with? The biggest one, though, that is most likely the case is going to be adherence. So if we've talked about HIV PrEP before, and in the early PrEP trials in cis women, there were similar results to this DPEP trial. So HIV PrEP was not shown to be significantly effective in reducing HIV risk in these women. And then later trials showed, well, it was actually unfortunately due to non-adherence. With the DPEP Kenya trial, you would assume, so the majority of these women did report significant adherence. They did say that they were taking it. Plus, you would assume that with this group who is already taking daily HIV PrEP, that they would be able to take an additional medication for STI prevention. More recently, however, they kind of looked back and they did hair strand samples, and then definitely noted that adherence was very poor. So we may see this, you know, more data needs to be looked at, more studies need to be done in cis women, but we may have a kind of a similar effect where this could be useful for cis women later on. So how to prescribe DoxyPEP. It is taken as 200 milligrams of doxycycline, taken within 24 hours, but no later than 72 hours after condomless sex. I always have a little schematic because it's nice to just print it off so you can explain this to patients too. So if they had intercourse on a Saturday, they should take ideally, you know, this 200 milligrams as soon as possible. But like I said, ideally within 24 hours, could potentially still take a dose through Tuesday. If they continue to have unprotected intercourse, so this is condomless oral, anal, or vaginal sex, then they can continue taking one daily dose of doxycycline, but no more than 200 milligrams within 24 hours. So concerns with this, certainly lack of efficacy or data in certain groups, potential for increased drug resistance. So if we're using this modality of PEP and also like PRN, you know, PEP, then is it going to increase drug resistance to tetracycline? And, you know, I think the framework that we need to keep in mind with this is that when you're using DoxyPEP, you're reducing the need for antibiotic treatment kind of post exposure. So basically, I mean, you're, you know, with there was a 50% reduction in ceftriaxone use for the individuals that took DoxyPEP in the earlier trials in men who have sex with men, which I think is great. So by taking this PRN medicine, you're actually reducing overall usage of antibiotics. Other thing too is, I mean, yes, this is going to be, you know, something to consider, and certainly something that we'll keep in mind, you know, as this kind of becomes more widely adopted. but it's just such a small portion of individuals who are taking doxycycline anyway. So just kind of keep that in mind. Impact on the microbiome. I mean, certainly we would consider that if you're going to have a patient taking doxycycline, that there could be that impact. We don't know how clinically significant that is, though. So that's something else that needs to be looked into. I'd say probably the one area I would consider is with HIV positive individuals, and potentially the impact of clinically significant impact maybe on their microbiome might be a little bit different. But nothing so far that we've seen. So what counseling can we provide? So a self-assessment of risk. My approach is usually to, if I had, most of these patients that I see are those that are on PrEP already. But if you have a patient that has had a bacterial STI, or presents with one, or has history of multiple sex partners that they're reporting to you, I kind of approach it like, hey, there's this thing. I kind of offer this if you'd like to have it on hand. It's for condomless sex, but you can kind of take this dose of doxy and it will, it can potentially reduce the likelihood that you'll become infected with primarily syphilis or chlamydia, sometimes gonorrhea as well. And a lot of patients, they just kind of like to have it on hand. What we know about effectiveness. So last time when I talked about it, overall an 80% risk reduction with syphilis and chlamydia. About a 50% risk reduction with gonorrhea. But again, remember that, doxycycline is first-line treatment for chlamydia. It's second-line treatment, and even kind of with the penicillin shortage has been kind of primary treatment for syphilis. For gonorrhea, there's already about a quarter of gonorrhea cases that are already tetracycline resistant. So we wouldn't expect DoxyPEP to work as well in that regard. And then review how to use it and acknowledge unknowns. Like we don't know how it's going to affect antimicrobial resistance. We don't know yet how it's going to affect the microbiome. So those types of things. Just remember, it's part of a comprehensive package of sexual health services. So we're not just saying, hey, use DoxyPEP and you won't get, a bacterial STI. We should be educating patients about primary prevention, risk reduction counseling, using condoms, vaccinate our patients, Hep A and B vaccines, HPV, monkeypox, meningococcal vaccines as applicable. Also, offering HIV PrEP, HIV PEP if there's an exposure, for HIV positive individuals, counseling them that treatment is prevention. And then so this is kind of just one of those arms. And then they should continue to be getting STI testing at regular 3-month intervals. And then addressing social determinants of health. So also, considering mental health and substance use treatment, increasing access to care, and then also policy. So kind of moving towards a landscape where we can offer this to more individuals. Just a schematic, it was an ad I saw, and then some resources. So.
Thank you so much, Kaylee. Great presentation. I'm so happy you're able to finish the second half this time.
Yeah. I know that some people might not have been on for the first half when we started it last week. So what questions do you guys have, or has anybody heard of DoxyPEP, or you've been using DoxyPEP?
Everyone's welcome to unmute, and if you prefer chatting in, I can read the chat out loud for you. Dr. Voltaire, I see you unmuted. I don't know if.
Yeah, no, I'm kind of in between places, but no, I think it's great. I mean, it's a great option for some of the population that we work with. So we'll definitely throw it into our counseling to patients and see what their perspective is on it, so.
This is John, has anybody used it? Or had it not work?
Haven't used it yet.
Okay. I'm going to comment on 2 things, and that's if you were taking a Augmentin or Decaflex or a quinolone, my concern about the impact on the microbiome would be high and risk of C. diff. But if you had to choose a designer drug to take for prophylaxis, tetracyclines or Bactrim really are it. Your risks are super low. Not to say we can't mess up things that we don't understand, because I'm sure we do. But in terms of C. diff risk, which is kind of the low hanging fruit for microbiome screwing up, is developing C. diff. The other one would be, becoming resistant to what I would consider a life-saving group of medicines, like a beta-lactam. You're not going to risk that with tetracyclines, number one. The second, in terms of development of resistance, it's going to happen for gonorrhea. That bug is good at it. Chlamydia probably will happen, but honestly, the scariest of all the STIs there is syphilis. It's not going to happen. So while it's a really cool-looking bug, it's a spirochete. It is not good at some things, and one of the things it's not good at is becoming antibiotic resistant. Thankfully, really, we only talk about azithro resistance, but beta-lactams and tetracyclines, we don't really talk about resistance to it. It doesn't have the genetic wealth to become resistant, so I don't fear it. Remember, like Kaylee was saying, we use doxy for prophylaxis and other things like Lyme disease, other spirochete diseases, and we don't talk about resistance there either. So, yeah, just all. I have low risk, potential benefit. My own experience using this is I've still had breakthrough STIs, but it's primarily because people haven't followed the algorithm that Kaylee showed, and they've taken DoxyPEP once and then continued to have intercourse and not taken it again afterwards. So they thought kind of like that's education fail on my end. I needed to tell them you got to keep taking it if your exposure is continuing. So.
And that's a good point too, because that would definitely be something of concern. So again, this is not 100% effective. So what do you do when you have a breakthrough STI? Is it going to be managed differently? Do you, if somebody has said, yes, I had an exposure to syphilis, would you wait until their, testing is back before you treat, or would you go ahead and treat? I think with my approach, if somebody has been taking DoxyPEP, if they have a known exposure to syphilis, I would go ahead and treat, just because of the implications with that. With gonorrhea, I would also probably go ahead and treat. With chlamydia, I may just wait until the testing actually comes back, just to verify that it actually was an exposure and would need a full 7-day course of treatment. So just other things to consider too is, yes, you are going to have incident STIs with this, but the goal is to reduce that risk, not to eliminate it completely. It's just one strategy. And then again, I guess another thing just to make sure that we bring up is this is for bacterial STI, so it's not going to have any protection for herpes virus, HPV, HIV. What else am I missing? And viral STIs, monkeypox, those kind of things.
Thank you both so much. Any other questions, comments from the group, or experience with DoxyPEP? All right, and Kaylee, any other comments on your presentation or anything else you wanted to mention to the group? I know you just did a whole presentation on it, so but wanted to give you the opportunity in case you did.
No, thank you guys so much, and hopefully we can get some time back today.
Yeah, absolutely. I think with that, we'll give you guys some time back. My only announcement is that the next session will be on February 22nd, which is also Elizabeth's birthday.